My name's Michelle Graham and I'm a Programme Manager for the Stroke Service Improvement as part of 1,000 Lives Plus in Wales.
And I'm Mike Davidge and I work in the central 1,000 Lives team where I advise on improvement and also look after all the measurement aspects of all the different programmes that we run. And so you've got a well-rehearsed double act this afternoon. And the first slide goes to me because a little bit about Wales. So, okay, here we are. Hands up if you are not from the UK. Hey, right, okay. So you might find some of this interesting. On the other hand, you might not. But Wales is that small bit of the UK that sits to the left-hand side there of the main island, and it's about 3 million people. And about 90,000 people work for the National Health Service in Wales. So that's a little bit about the country. Now Michelle's going to talk a little bit about stroke services in Wales.
Okay, so as you can see on the map, we've got 15 district general hospitals in Wales. A few facts and figures on the front there. We have about 6,300 admissions a year with stroke. Our age standardised admission rate is 127 per 100,000 population, and our 28-day mortality was 18.7% over the period of 2008 to 2011. Of those 15 DGHs, 14 of them provide acute stroke services, and then you'll notice this great big enormous hole in the middle with nothing. It's not really a hole, it's PAWIS. PAWIS is a health board that doesn't provide any acute services whatsoever, and actually I wouldn't be cruel if I said that there's probably more sheep than people in PAWIS at the moment. They also have the difficulty that their acute stroke care is not only provided by the top end of Wales and then down in the middle at Prince Charles and Neville Hall and Brongleis, it's also provided by a couple of hospitals in England as well. So they're working with two different services. So now I'll take you back to Mike, as you've got an idea of what the scale is, and he's going to take you on our journey.
Okay, so what we're going to do this afternoon is take you on a journey, the journey that we've taken to improve stroke care from where it was back in 2006 to where it is today. And it's a journey. And along the journey, there are going to be 4 points where we'll stop off and admire the view. And those 4 points represent some of the key learning that we've had with this programme. So that's the journey we're going to take you on from our point of view. But what we'd also like to do is encourage you to think about a journey of your own. Maybe some of you are already engaged in a large piece of service improvement work. And you've come along today because you're interested to see how we have achieved what we have achieved. So what is your journey? The journey that maybe you're embarked on already, you're already doing, or something that you want to start, a journey of improvement. What I'm going to get you to do is just to think about that. I'm going to give you a minute or so just to think, what's my journey? Because we're going to come back to your journey at various stages throughout this presentation. So this is a time for you to stop and think and say, what's my journey? Okay. Good thoughts? Okay. So here's the first one. The first viewpoint is one of these. Okay, so we have a saying in English called a burning platform. Now, does that translate into your language? Yeah? So you understand what I'm saying? This is something where if you stay on that too long, you're going to get rather hot. So you have to jump off. And that provides, or can provide, a springboard for change. What was ours? Well, ours was this. Back in 2006, England, Wales and Northern Ireland participated in an audit of stroke care. All the units across England, Wales and Northern Ireland collected data for about 3 months of the year in 2006, and that was compiled into a report about stroke care across those 3 countries. And you can see some of the results. So they ended up with this thing called a key indicator score. Lots of detail behind this, but the most important point about this graph is that higher on this scale is better. Okay? And where's Wales? Over there. Okay? Very much in the relegation zone. So that was a bit of a wake-up call. So what was the response? Okay, so Michelle is going to talk about those first responses. So the fire's been lit, okay, on this platform. It's not terribly big yet, but it's starting to look a bit worrying. So what happened, Michelle?
Well, before I tell you what happens, I'll just mention that the little indicator down the side there is our timeline, and you'll watch the arrow move up as we go through the years of our journey. Mike forgot. So what happened is in 2007, the minister got quite edgy about the fact that we weren't doing very well with our stroke services in Wales. The clinicians were all screaming about the problems they were having and things weren't going very well. In August 2007, the Welsh Health Circular number 52 came out from the minister and confirmed that stroke was a priority for the National Health Service and social services in Wales. And it set out the actions that they said were required from commissioners and providers in Wales to be completed by March 2008. It announced a formal programme of work would be published and that acute stroke units should be a priority in Wales. It instructed a partnership to be formed, and that partnership was formed by the Wales Centre for Health, the Public Health Service Wales and NLIAH, which is our National Leadership and Innovation Agency for Healthcare. I am English and I can't speak English today. So that one came out. Then in 2007 December, the next one came out, which was number 82. This set out the formal programme of work that had been alluded to, and it said what was to be undertaken, and again the deadline was March 2008 for all health boards and social services to have action plans in place. So there were lots of plans to take things forward, but as you all know, working in healthcare, stroke was just one of many urgent priorities that had to be addressed. So by March 2008 we got lots of plans, but there was still little apparent action and therefore no impact. So basically we were continuing to burn. So then there's nothing like a bit of media exposure to increase the stakes. BBC News early in 2009 quoted Tony Rudd. You can read it for yourselves there. He assessed services in Wales, England and Northern Ireland 2 years ago and said services in Wales were scandalously bad. Just in case we hadn't got the message, to reinforce it, he actually attended the Welsh Stroke Conference to tell us all how bad we were, just in case we hadn't noticed. So the flames are now an inferno. Over to you, Mike.
Okay, so that's our burning platform. Okay, very high profile media exposure, saying we were rubbish at stroke. So in your improvement journey, do you have one of these burning platforms that you can use to get that energy for change? What I'd like you to do, and this will now involve you talking to the person next to you. Okay, so I should have warned you, shouldn't I, before you came in? Anyway, so that may mean that actually you might have to shuffle along the seats a bit. What I'd like you to do is turn to the person's next to you and just share what your journey is and whether you've got a burning platform. something that you can use to help get that energy for change going. Okay, so I'll just give you a couple of minutes. So once you've done your talking, then listen to the other person. Quite helpful. Okay, off you go.
Okay. I'm calming down.
The time? Yeah. I don't know what the time is. I can't remember what the time is.
I left it in my bag. Oh, actually.
Yeah,
got it out because I've written.
Yeah. So we should be over there. So we should be starting the second exercise at 4 o'clock. Second starting okay, that's second, well, that's well. Keep to this time, we'll keep to that as if we were doing it. So we're starting the second point at 15 minutes in, so that's good. Okay, so we're at about right so far.
I've stopped sweating now. I'm starting to get into it. Oh wow, that worked well.
Because I know what that is. It's just a little view. It's flickering, isn't it? And you've got 2 in a row, haven't you?
Yeah. 3, I think.
So that's your main chunk, isn't it?
Yeah.
Okay, fine. Okay.
I keep looking at my wrist. Let's have it.
I'm going to stop there now. Okay. If you'd like to just wrap up those conversations, please, and we'll move on. So you've obviously got plenty to say for yourselves, which is good, and hopefully you are now sharing that journey you're on or want to be on with others, and we will come back to that journey again a couple of times. So now we're on to the second of the viewpoints on our journey, and that is a good process. We need a good way of enabling teams to improve from where they are, and Michelle's going to take you through what we did. So Michelle.
Okay. So as you can see from our little indicator, we're moving along the timescales now, and we're now in spring of 2008. So in April, the partnership that I mentioned before published the Stroke Service Improvement Programme. And we all know that government instruction isn't really enough, but one of the initial work streams of the improvement programme was the development of the All Wales Stroke Service Improvement Collaborative. And this was charged with taking forward the improvement of acute stroke services across Wales. ORSIC, as we call it fondly, because it's a lot easier than the other mouthful I just gave you, was based on an evidence-based clinical change model, which we've adapted and quite successfully used in Wales in the past to deliver demonstrable improvements in health care. There are 3 elements to the approach that we use. We have the breakthrough collaborative structure, the IHI model for improvement, which I'll discuss a bit later, and driver diagrams, which I'll discuss a bit later. So basically, the collaborative creates a structure in which interested organisations can easily learn from one another and learn from recognised experts as well. So it brings together groups of clinicians and practitioners from different healthcare organisations and gives them a structured way in which to work to improve an aspect of the quality of their service. Is everybody familiar with the Ihi Breakthrough Model? Oh, good. So I suppose if you look at the model, we're now on our chart we've selected the topic, we've had the expert meeting, we're developing the framework and the changes and planning group. So we're just on the precipice of learning set 1. In spring and summer 2008, look at our little guide again, we developed the driver diagram. This was a really busy period for us in the collaborative. We had the evidence that enabled us to concentrate the acute stroke pathway that we had and turn it into a driver diagram. So because we were talking about acute stroke services, we were talking about 0 to 7 days. We took the evidence-based interventions and focused on the processes of care and then grouped them together in the 4 bundles you can see up there. So we had symptom recognition, diagnosis within 3 hours, first day bundle, first 3 days, and first 7 days. The care bundle approach itself reduces variability and it improves reliability, but it still allows the adaptability and it doesn't prevent innovation occurring. So we also provided the how-to guide, and this actually looks quite basic now to the ones that we provide. This was the first edition we did. I think we're on version 10 now in 2012. And the how-to guide was published underpinning the bundles with the evidence, as well as giving guidance on the IHI model and examples of PDSAs. And we also made all of this work available on the 1000 Lives website as well, so it was quite easy for people to access, either in computer or in paper form. So we got the process, we've got a burning platform. Our third viewpoint is having the right support. Sorry about the scary photos. So in summer 2008, while we were doing all this, we established the ALSIC faculty. I suppose is the best way to describe us. So we had clinical expertise, which was provided by the grey-haired lady right over to your left, which is Anne Freeman. She's our clinical lead and she's a consultant physician. I, at that time, was employed as a clinical advisor in my role as a clinical nurse specialist in the field. Our improvement experts were Dr. Alan Wilson from the National Leadership and Innovation Agency for Healthcare, which we call NLIAH, and Chris Hancock, who I think is here. Do you want to give us a wave, Chris? Thank you. And we also had data experts. You've already met Mike. And we had Nick Tyson from NLIAH. So all of this was overseen under the watchful eye of the lady on the top, which is Michelle Price. Oh yeah, it also helps to be called Michelle to work in the Stroke Collaborative in Wales. Should have mentioned that. Michelle had the clinical credibility of being a neurophysiotherapist, but she also had service improvement experience. So she'd got the credibility with the clinicians on the ground, but she knew the process inside out and was able to steer all of us in the right direction. And I think actually having a really good project manager and strong leadership in that way really benefited us all the way through the process. So we're moving along and we're moving up. We're going from summer now to November in 2008. So we identified the teams. We've got 14 stroke teams across Wales, and we invited them to join us in our Welsh Stroke Collaborative. And on the 4th of November 2008, we launched our first learning set, which was Learning Set 1. So this one was really for the teams to identify themselves, to start to look at their local issues, to really introduce the model of improvement, to give them a glimpse of the database that Mike had been developing over the summer, and also to introduce, as I say, to introduce the IHI model of improvement, but to get them to start getting used to using PDSA cycles and to start working on small cycles of change. I think one of the early ones that we actually uncovered in Learning Set 1, we had a team from Cardiff, and we asked each team to sort of look at something that they might be able to do PDSA on the learning set on the day. And they were having great difficulty in getting their CT heads done in a timely fashion. The system that they had, doctor requested a CT head, that went in a box twice a day. Someone took them out of the box on the unit, took them down to the radiology department where they sat in another box until somebody else looked at them and then decided to do a CT head. So they looked at this, did a PDSA cycle, off they went, and they, without spending any money at all, but just going and talking to their radiology colleagues, talking to the team on the ground, they now write out their CT head, the form goes straight to radiology and is seen by a radiologist straight away, and then a decision is made. So they've cut out all that waiting time. But it was a big gain, but a small cycle of change that they piloted, used, and then carried on. And that was really good because it starts to reinforce the improvement message. We also held we appointed team leads for each of the local teams. I think you refer to them later as sacrificial lambs. We have one sat in the audience, actually. Do you want to put your hand up, Kylie? She was one of our first sacrificial lambs. It meant the whole team took the approach. We had the team lead, and then they all went away, and everybody just looked at the team lead and waited for them to do everything, basically. And it was their job to rally the team. So we had 3 learning sets altogether. The one in November, we had one in February 2009, which Mike will tell you more about because that was about data. And then we had the 3rd learning set in July 2009, where all the teams came back, and really that was their learning set. They were able to tell us their stories and the progress that they'd made. In between times, we kept to the collaborative breakthrough model. So myself and the program manager did regular visits for support with all the teams. I think one of the biggest and we also did WebExes, and we organised meetings that were just for the team leads to try and give them the skills and the tools that they needed to be able to go on and keep the momentum going. The biggest difficulty we had, and hands up here, I was a clinician with no service improvement experience at all, was the data. The clinicians on the ground had a real hate isn't too strong a word, a hatred of data. I think most people were frustrated that things like the Royal College of Physicians audit cycle meant every 2 years, for 3 months, everybody ran around making sure everything happened that was supposed to happen. Audit went ahead, and then everybody just went back to doing exactly what they were doing before. The audit cycle was never completed and changes weren't made. And clinicians were very, very wary of collecting data for data's sake. You know, and what are we getting out of this? What's the point of collecting this data? How is it going to help us in our everyday life, and what's going to be done with it? You know, is this another paper exercise? So I think the most important 2 messages there are data, which Mike, you're going to explain how we supported them through that and gave the data value. But the fact that the teams, to constantly support the teams, and in specific the team leaders, and make sure that they are equipped to be able to carry on and take this, what is a pilot at this stage, forward and make it into something sustainable and achievable. Mike.
Thanks very much. And I can't emphasise enough, really, the fact that Michelle and the other Michelle, they must have worn the car out, I think, because they were travelling around Wales and giving that support, and that was really, really valuable. So it's your time to talk again in your little huddles. So the questions to address now are, have you got a process, a reliable and recognised process of improvement that you're going to use in your improvement journey? Have you got that? And the second one is, have you got the right support? Have you identified the right people that will support the teams in their journey? Okay, so have a little chat about that. Off you go.
Slightly ahead of time now. Is that okay? My lips are sticking to my teeth.
So we can give them 5 minutes, can't we?
Yeah. I did actually, believe it or not.
Did you?
I did pure and applied A-level maths. Yeah.
Goodness me.
Yeah. I jacked because I was getting checked out of English Lit. So I wanted to be a solicitor, and I went off and banned pre-nursing course because I didn't want to go home and tell my parents that I was going to get moved off the course. I said I wanted to be a nurse instead. So I could jack on my A-levels, but I loved math, and it was one thing I was good at. Absolutely loved it.
So it should be
Yeah, I did pure and applied, not maths and stats.
Maths is applied, it's
yeah.
problem solving, maths is applied,
Yeah.
maths, isn't it?
So I still do that. So John, we go anywhere, and he always makes me work out the tax percentages in my head, which never used to be 20%. It's a lot easier now.
17.5, isn't it?
Yeah.
I can't do mental arithmetic now, haven't I?
That Swedish woman, I felt so sorry for her because she did better in English than I'd have ever done in her language. But it was she'd obviously learned it verbatim.
That's impressive.
I just, yeah. I always feel really lazy when we come to things like this. this. And everybody does everything in English. Can you stop them?
Okay, if you just bring those conversations to a close, please. We're going to talk now about the fourth of our viewpoints. So we've talked about the burning platform, we've talked about the good process, we've talked about having the right people. Now we're talking about data. Okay, so I'm going to ask you a question now that I ask nearly all the courses and workshops that when I'm looking and talking about measurement. And that question is, put your hand up please, if you liked mathematics at school. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. One or two of you are not sure. One or two of you are looking a little bit ashamed of the fact that you put your hand up. Now I reckon that's about 40% of the audience, okay? When I ask that question normally, I only get somewhere between 20 and 25% of the people put their hands up. Okay, so you're abnormal. You knew that.
That's why we're here.
That's why you're here, thank you, yes. But even in this room, the majority of you it wasn't your favourite subject. And the problem that brings is that you have that mental image of the maths lesson from hell. Yeah? And you bring that with you into a work context, and therefore you avoid data if you can. So, I always say at this point to people, there's good news and there's bad news. Okay? The bad news, because people want the bad news first, usually, is that you have to do data if you want to do improvement. That's the bad news for the 60% of you in this room. The good news is that it is not difficult. So, how do we get over this? Well, let me put it a different way. Let's say the outcome we're looking for is that people are using their own data to help themselves improve their service. Okay? So the outcome we're looking for is that. I've given you a hint, haven't I now? What's the answer? The answer is we need a good process. So what we teach, thank you, Michelle, is a process. And if you go on our stand, you'll see something that looks a bit like this, and it's in there. But it's a 7-step process, and we started with the aim. What are we trying to do? And in this case, the Stroke Services Collaborative, we chose the measures and we defined them because we'd got those 4 care bundles. We said, really, if you agree these care bundles are really important to help you manage your stroke patients really well, then you need to know whether you're applying those care bundles for every patient, don't you? And the answer was, yes, we do. Okay, so how do you know that you're doing that? Well, we have to measure, don't we? We have to count. Here's patient 1, here's Mrs. Jones, and did we do care bundle 1 for her, yes or no? Care bundle 2, yes or no? Care bundle 3, yes or no? Care bundle 4, yes or no? Now, when you start looking at the different elements in those care bundles, we were looking at asking people to collect somewhere around 30 items of data. It was around about that. That's not trivial. And when people realised that, sitting in that room, they thought we were completely barking mad. Why would we collect all that data? How can we collect all that data? We're going to talk a bit about that in a minute. But the other parts of the cycle are a little circle. You can see we go around a circle, we collect, we analyse, we review. So let's look at this collect business. What we said was, you need a plan. It isn't just going to happen. It's no good asking Kylie, as the sacrificial lamb, to go away and do it, which is what some teams tried to do. We need a plan. So what are we talking about? What's the format? Who records it now? At what point in the care pathway do they do it? Where is it stored? Where can I get it from? How reliably do we collect it? Lots of teams here did a few PDSAs around data collection. And what are the issues we need to resolve so that we have a process of collecting the data? Okay, no scary maths so far. The scary maths, to some extent, come in the next step, which is analyse and present. But that's where we gave them a bit of a leg up. Okay, we gave them a helping hand, because what we did was we created a data tool in Excel. And this is the front screen. And this is the data collection sheet. And here are some graphs. So all they had to do, was collect their data, enter it into the spreadsheet, and away they go, because the graphs are already there. I've given you a little graph here, which is one of the items of one of the care bundles. So this is the percentage of patients who were sat out of bed or mobilised. It's about mobilising patients in the first 3 days after their stroke. So did this happen? Percentage of patients in this data set. And you can see these numbers along the bottom here, and they are 0. That means it wasn't happening at all for any patients in that time period. That's not missing data, that's genuinely it wasn't happening. Now, of course, I don't know about your health service, but in our health service in the UK, if you showed that performance to any important manager, you'd be shot on sight. So we don't tend to share that information. We try to either suppress it or make it look better, because any bad news is, well, people don't want to know. But what we were really encouraging the teams to do was to share the bad news amongst themselves, not in a punitive way to say, you're terrible, but actually to say, we've got a problem and we need to solve it. So that was the journey we were trying to get them to move on, and we used this tool to help them do that. We then moved on to review. To my mind, this is, we've got some data, we've got a graph, it's telling us we're at 0 or wherever we are, so what do we do about it? This is the bit in the data using cycle that's really, really important, and it's one that's often missed out. So we had to encourage people to actually look at their data. They weren't used to doing it. And so Michelle and others were running how to interpret the data sessions. I've got the graph in front of me. What's it telling me? What do I need to do? Now, this data is based on those care bundles, so it's really focused on clinical interventions. But because we're now aggregating it up and looking at all patients running through the service, we're moving into management territory. And so what we're providing here is a common language about what's going on in the system that we can track in pretty much real time. And we can have those conversations between clinicians and managers. So that's using the data. Okay, so it's your last opportunity to talk for a little while anyway. And that is, what's your approach to using data? Do you have one? Do you need to get one? Have those conversations with your friends, your new best friends.
On time.
Just about to. That's the end of that. We're about to start that. So 44. Yeah, that's good. Oh, 42. Okay, that's good stuff. That'll give us time for a few questions, possibly.
last one. Who's on his messaging?
That's good. That's good. Is it Julie? Is it Julie with Karen?
Yeah.
You must be talking about something.
Well, different services. So Julie won't know about all the stroke work because she's infection control as well. Sorry, I nicked your sacrificial moment.
It's fine, no, it's fine. It's fine. Right, then, we want to play that again and again because it's quite a useful one. Did I cover everything I was supposed to cover?
Yeah, you just missed off the
Yeah, okay. But you mentioned it anyway, actually.
Yeah, I did.
So that was okay. So we're over hosed now, aren't we? What's your bit?
So do them one at a time,
Yeah.
and I'll say.
And then we've got Jenny's own, which is that. Is that it? That's just me then, is it?
Then it's you.
Yeah, okay. Yeah. Okay, we will get them going.
To go.
We should be starting the next one at 11, so that's a couple of minutes. How are you feeling?
Okay, yeah. Do I look calmer?
Yeah.
Have I lost that manic?
You were never looking that many, but I could tell. But only,
Because you live.
yeah, because I know.
I was getting to my stride at the end. I love it because they've all come in separately and they're all chuntering away.
I think probably 2 or 3 of them. I think some of them probably all know each other or something. But it's good having that conversation. It's quite good. Okay.
You're going to round them up?
We'll round them up, I think, yeah. So what's 20 minutes, does it?
So it's the ducks in a row.
Oh, okay, yeah. Okay. Let's, again, for the last time, draw those conversations to a close, please. And I'm going to hand over to Michelle now to talk about the last lap.
This is the bit where finally we got all our ducks in a row. So all the things that we needed to be in the right place at the right time to be able to take things forward. So the first one was the continued support. As I said, we had the last learning set for the acute stroke in July 2009. The support didn't stop there, it just wasn't quite as intensive because by now we'd picked up TIA and early rehabilitation to take the same approach with. So we'd started the process again, but the support was there. And in December 2009, we held a team day just for the project leads, looking at leadership and critical analysis, because again we wanted to make sure they had the tools to be able to carry on and sustain this and keep the momentum going, because as we were pulling out, we needed this to carry on if we wanted it to move on from just being a pilot. We then had another duck that came into the row at just the right time: intelligent targets. The government started to work in a different way. We'd always had an annual operating framework, and the government decided to pilot using more intelligent targets that were driven by the clinicians and the evidence, as opposed to things like 4 hours waiting time in A&E. Things that actually made sense and people could do something about and would actually make a difference to the outcome for the patients, rather than them just being moved around to fudge that they've been 4 hours in A&E before they breach. So the intelligent targets, they got together with a specialist group, and because of the work that we'd already done on the pilot project in Orsic with the acute stroke, they asked us to use the same model to take things forward. So they looked at stroke, TIA, acute stroke, and early rehabilitation, mental health, unscheduled care, and CHD. So obviously we carried on with the stroke and carried on developing driver diagrams. The intelligent targets were then incorporated into our annual operating framework, and that became the annual quality framework. So we were starting to look at things in a different way. So it just gave us another duck in a row. So we've got the teams, people are motivated, they're doing the work, they're following the evidence, and now we've got some support to carry that through. What they did ask, though, is that all the teams would be achieving 95% compliance with these bundles by September 2010. Then, our third little duck was perfect. We had a serendipity moment, an absolute stroke of luck. We have in Wales, we have 7 health boards and 3 trusts: Cancer, Public Health Wales and Welsh Ambulance Service. And they meet regularly for a day, all the chief execs of the boards of these groups, at what is known as a Team Wales Day. And our faculty lead, Alan Wilson, who I mentioned earlier, was doing a teaching session for all the execs and decided to use the session that on stroke data to show how data could be used to improve services. And it also meant that it was going to give us the opportunity to marry up what the clinicians were doing on the ground with what was going on with their executive boards and start to marry the two up. The team leads, our sacrificial lambs, weren't quite as excited as we were, I have to say, at this, about the fact that they were going to have to present their data to their chief executive. But we got the tissues out, held everybody's hand, and we did a data analysis session with them a couple of weeks before, so they felt more confident. And all we asked them to do, we did an hour session, and they sat at the table with their executive board, most of which they'd never met in their lives before, and they presented the data, and it was really exciting. Would you say, Kylie? Nerve-wracking, but then exciting, because they were really interested. Well, why aren't we achieving compliance in this? What's going to happen, next? They knew about the annual operating framework targets and the intelligent targets. And this was like manna from heaven. Well, this all makes sense, and we've got this information, so how do we take this forward in our own health boards? So that was our bit of serendipity. And then it's taken it from pilot to performance. We weren't going to be carrying on supporting this. The momentum is still there. We've got the intelligent targets, we've got the exec boards engaged, but how do we take this from pilot to performance, and what happens next? Well, what did happen next was in July of 2010, we'd slightly altered the acute stroke bundles to marry up with the intelligent targets, and we handed everything over, lock, stock and barrel, to our DSU, which is our delivery and support unit, so that they could monitor the data that was coming through and use that to work with the teams to carry on with the momentum and actually safeguard and measure what we were doing and check who was, complying, who wasn't, and start to give some accountability to this to be able to carry it on. So, supportive and slightly big stick, Andrew? We have a member of DSU here. Sorry, I'll just point. So we had all our ducks in a row. So we're at the journey's end now. Thank you. I wanted him to wear a sequin leotard and be my assistant today, but he refused. So this is, you can't see the dates very well, but this takes us from early 2009 all the way up to 0.5 is today. So data item 1 is our initial compliance data. So it's horrible. It's all over the place and it's completely meaningless. And this is when we first started and the teams were first starting to get to grips with the data, and some were doing it, some weren't. Some were doing bits, others weren't doing anything at all. Point 2 is all the units are now collecting data. We're now at probably November, December 2009. And the data we're getting is starting to be more reliable. And you can see things starting to even out. And some of the bundles are even creeping on. And we'll admit now, and I'm sure Andrew would agree with me, our first hours bundle has been one of the most difficult. And the first days bundle, getting patients to acute stroke units in a timely fashion. Point 3 is where we had that Team Wales event. And you can see there's a step change when the chief execs all suddenly woke up and saw what was happening in their hospitals and became involved. So we'd married up clinicians and executives and middle management. I think middle management, I think most team leads would agree with me, still poses a bit of a problem, and we occasionally have to circumvent them. Step 4 is another change, and that's when we handed over to DSU. And all of a sudden, this was no longer a pilot or a project, and people were accountable for what they were doing. And the processes were being measured and monitored. And when you go along to 5, that's the latest data that Andrew's kindly provided us with from DSU. That's where we're up to at the moment. There's a lot of unfinished business, but because we've got the data, we know we can pinpoint what we still need to do, rather than running around like headless chickens throwing money at everything. You're actually able, and the teams are able, to look at where their problem areas are and focus in and zone in on that, which is how I know we're struggling to get all our patients into acute stroke units still in a timely fashion. Thrombolysis is coming. We are thrombolysing. We need more dedicated stroke units. Some of the units are still just provided co-located beds on a general medical ward. We've got hyperacute phase coming, and what was on the initial bundles was 24-hour access to CT scan. We now need to make sure that should be happening within 4 hours, as you know, with thrombolysis as well. Some areas are picking that up well, others aren't. So we've got a long way to go. The bundles are being reviewed and adapted at the moment so that they will be changed to be in keeping with what we're doing. But to me, I think the biggest measure of success with all of this has not just been my personal journey through service improvement, going from novice to not as much of a novice now, but it's the fact that at a Welsh meeting a couple of months ago, it was suggested to the teams, and there is a group of physicians there, that actually perhaps for the next year we should put this data collection to one side and concentrate on the new RCP audit. The same physicians that in 2008 were not interested at all in taking part in this work. And it was something that their teams could do if they wanted, but it wasn't really going to have any relevance, and nothing was going to happen as a result. We're up in arms and horrified at the thought that we were going to take their databases away and their data away, because they've actually used it and they find it valuable and they've been able to improve their services as a result of it. And now I'm just going to hand you over to Mike to conclude.
Thanks very much. Before we move on to the last slide then, I just want to emphasise that these graphs, these run charts, show you bundle compliance across the whole of Wales, all 14 stroke units combined. Okay? So we're looking at 95% compliance in that bottom bundle there, around about 95 there, and the top one, it's only that second bundle where we're still running at about 80% compliance. That's across the whole of Wales. Often when people present work, it's for a unit or a team. This is for 14 teams across the whole country.
How much range is there?
Well,
20.
okay. In this bundle here, if you're at 98%, I suspect not a lot. And that's probably true for 3 of the 4 graphs here. For that one there, at 80%, then when you're going to see variation. I don't know what the lowest is, probably. Come and see us afterwards. I'm sure Andrew's probably got the figures somewhere. But we are talking about only that bundle where there is significant variation. And, of course, that's the bundle compliance. Each bundle is made up of a number of separate measures. So most of those will be at 100%. Because you won't get this level of compliance at the bundle level unless you are at 100% on a number of the sub-bundle. So that's for the data. So we've come to the end of our journey, and as Michelle has said, it's not really the end because there's still some work to do. But we've taken you on a journey from 2006 to 2012, as we say. And we started with that burning platform. What's going to be really interesting is that the Sentinel audit for 2012, the data will be collected April to June this year, like now, right the way till June. So, and the report will come out later in the year, and it will be really interesting to see what's happened to the Wales data when we get that back. We talked about that process. A good process is really key to getting a successful uptake. And the model we use energizes frontline staff because it puts them back in control. So whatever model you use has to do that. Has to energize frontline staff to make the changes and empower them to be able to test the changes they want to make. Because they're the ones that know. They're in that environment day in, day out. They know what the issues are often. We talked about having the right people in place. So that was a mixture of skills and credibility to drive the work forward. Because we've given you a nice story this afternoon, but any story is not easy. There's always difficult times, and you need a good team around you to enable you to get through that. We talked about the data, about how absolutely essential that is. And what this data does is it enables us to connect frontline teams to senior managers to the Welsh Government. And we're all talking the same language, using the same graphs. And that's really, really important. I will also say that a little bit of luck doesn't go amiss. That serendipity, that let's seize the moment opportunity. You may get those too. When you do, grab hold of them and use them. That's all from us. We're running out of time. We've probably got time for 1 or 2 questions. Finally, say if you haven't got a newspaper, do visit stand 23. That's our stand, and come and see us on there. I'm happy to. We're happy to take questions, aren't we, Michelle? Yeah. Okay. Yeah. Okay.
You register mainly the process indicators, the elements of the bundle, or do you register outcomes as well, like dying or functional status or living at home?
I'll let you do that one.
Okay.
We
We do. We do. On the database, we've concentrated on the reliability side of it this afternoon, but we have death, we have readmission, we have a function score on there. What's interesting, for me anyway, is that clinicians, when we started the journey, were most interested in that. Yet we're still getting difficulties with them collecting the data, particularly about functional score. Death is easy, generally speaking, to collect. But
Not
it's
good
interesting.
though, Mike.
Okay, right, yes. So,
in how many patients will you be doing thrombolysis, and how long will it take it for you to change to 4 hours time limit?
okay, I'll leave that to Michelle.
We're changing to the 4 hours now. You're actually working on the Andrews from DSU because we've handed over to them now. That's being worked on. And all of the DGHs are, 14 of them are doing thrombolysis, and we're going for 24/7, and we've also setting up regional networks. And because of the logistics of the area, we've now moved on a pace, and there are carts in place that allow telemedicine, so people can be remotely thrombolysed.
Okay, yes, sir.
So I'm going to comment on this actually as a subject matter expert, as a neurologist. In the past, we used to thrombolyze patients only within 3 hours. That's for the IV intravenous TPA. Nowadays, and that's a 3-year-old information, we have gone up to 4.5 hours based on the latest trial for the TPA. So we do have a window actually of another half hour, so you have 4.5 hours. But I'm very glad to hear this. Now, the poster actually will show the 30 data elements that you are collecting. The 30 data elements that you're collecting, it'll be shown in the poster.
Do we list
We haven't
them?
put a poster in.
No, you'll have to come and see us afterwards.
Yeah.
We'll tell you what they are
Yeah.
if you
All
want to
right.
know that.
Thank you.
Hi, really interesting. Thank you. Just interested in actually who actually inputs the data, because that is always a critical factor, isn't it?
Yeah.
We're back to our sacrificial lambs, I'm afraid. That's been a big sticking point. What did happen early on were some of the house boards released money to allow a clerk to do the data inputting. In some places that has continued, in other places that hasn't, and that's been a huge sticking point. And as we're moving on, and they're now doing TIA, which is often the same teams, and early rehabilitation, 7 of our units are combined, rehab and acute. You're looking to the same people again, and this has been a major sticking point. It is being done, but it's often being done by the clinicians, and I have to say in the majority of cases it's falling on the clinical nurse specialists, who seem to have increasingly broad shoulders as they're doing all this and are constantly told by their health boards there's no money. So people are trying to get clever. I know with the early rehabilitation, they're actually taking a laptop into their multidisciplinary team meeting and filling the database while they're sat there doing it live. You obviously can't do that for the acute stroke. Kylie, did you at one time experiment with other members of the team putting the data on your database?
Yes, we did, yeah. We involved the therapists as well, but now it's really so we can then specialists.
Yes,
So-
to redo them, the data. You can't extract them from your hospital information system.
No.
No.
Find that as reliable.
Okay.
Yeah, that's a good question. Thank you. Yes, sir.
Thank you. Just to follow on from the same question, really. The people that do your national audits and collect the data, it's a different set of people, is it? Or is there any economies of scale that it could be the same people?
Well, no, it's different people. Some people are using the audit department.
Yeah, but why?
Because the audit, the 2-yearly audit, isn't just in Wales, it's England and Northern Ireland, and they set the criteria for what that audit is. Now, there's a lot of overlap, actually, between what's in that audit and what we're doing here. One or two, there are some differences. In some ways, the audit is asking for more data, actually, than we collect. It's not the other way around. So it's that there's a large overlap. So when and
It's a different set of manpower as well.
I suspect that the audit will be done by
No, the
same
RCP
people.
audit
Yeah.
is usually collected by the same clinicians. Always traditionally in the past. Back to the good old CNSs.
But
yeah.
what was interesting to us was to see their reaction to taking away their database, and they didn't want us to take away their database, which suggests that for whatever the difficulties, and there are difficulties with collecting data, it's still valued locally, and that for us is absolutely crucial. If you can get the teams who are doing improvement to want the data, it's their data, and they're using it, you've won.
Thank you very much.
Thank you very much indeed.